this introductory point. Uh, First of all, the topic of the day is genetics and nephrotic syndrome, the topic which really needs attention. And now we have Dr. Jospal sir speaking on the same. To introduce the speaker, today we have the moderator, Dr. Satish Balan sir. Whenever I think about genetics, I remember a genes band because Satish Balan sir in one of his lectures had introduced a genes band which had all sort of multiple deletions and insertions. I hope many of us remember that slide. So I think he's a perfect person to talk on the moderation. He's the head of the department at KIMS. Over to you, sir, for the moderation. We'll have the lecture first from Dr. Jospi Paul, sir, and then follow it with Dr. Sonu Manuel with the quiz, and then we'll go for the discussion. Over to you, Satish Balan, sir.
Thank you, Vilesh, for that very nice introduction. So I think this is a very important topic, genetics, and genetics has come of age in nephrotic syndrome especially. And we have to know where in nephrotic syndrome you have to use genetics and what is the use of genetics in nephrotic syndrome. And I think without further ado, I will ask Dr. Jose Paul to talk on this. And you all know Jose Paul. He's a senior consultant nephrologist at Lissi Hospital in Ernakulam, and he's been around for a long time and a very good speaker and explains things in a very simple way. So over to Jose.
Okay, thank you, Dr. Satish, and thank you, Dr. Vilesh. At the outset, I would like to thank Georgie Kenan sir, MCure Pharmaceuticals, and Elias for giving me an opportunity to talk to you about the genetics of nephrotic syndrome. So this will be the structure of my talk. I'll discuss a case and I'll bore you with a little bit of genetics. Then I'll go with the classic features of inherited nephrotic syndromes. And finally, I'll conclude the topic. I'm not sure whether I'll be able to do justice to this topic within a span of 25-30 minutes, but I'll try my maximum. So we'll start with a case scenario. So there's a 1.5-year-old girl presents with a rapid onset of nephrotic syndrome, proteinuria, nephrotic range proteinuria, hypoalbuminemia, and edema. So it classically fits with a nephrotic syndrome. And after 6 weeks of standard therapy, you go for a 4 weeks of standard therapy with prednisolone 60 milligram per meter square, followed by a confirmatory phase, which runs for 2 weeks. There is no clinical or biochemical response. And a renal biopsy is performed, which shows FSGS. Now the questions which have to be answered, this will be asked not by the patient, of course, by the patient's parents, and for the treating doctor would be what is the disease, how do you make a diagnosis, what are the treatment options, what is outcome, and questions regarding family planning, like what will happen if they have another child. So these are the questions that have to be answered. So as you all know, FSGS, this is a class, the section of the glomerulus, and is, as you know, now it is thought to be a disease of the podocyte. So this normal glomerulus and the podocytes, the visceral podocytes support the glomerular capillaries. And whenever there is a loss of support and whenever there is a disease affecting the podocyte, there will be loss of support to this filtering glomerular capillaries. And as a result, they collapse and they become diseased. And the manifestation is like FSGS. And FSGS as a disease has been there for nearly 100 years now. It was discovered. It was described as a disease. And when we were DM graduates, DM students, we were taught that it is a separate disease. Now the concept has changed, and it is now thought to be a pattern of glomerular injury, and a variety of causes can lead to FSGS. Now that's a current concept. Now if you look at the causes of focal segmental glomerular sclerosis, you can have immunological causes, you can have genetic causes, then you have hyperfiltration injury, that is secondary causes. Now, with regards to immunological injury, there are candidate markers like SUPAR and things like that. And hyperfiltration injury as a result of obesity, nephrotic range proteinuria, normal serum albumin, all these things can lead to hyperfiltration injury. And if these two causes are ruled out, then you have to think about genetic causes. And included in the genetic causes are all these APOL1 gene mutations, which can again lead to focal segmental glomerular sclerosis. And the treatment is entirely different based on the cause. So if it is a secondary cause, you have to identify the secondary cause and treat the secondary cause. And if it's an immunological injury, you give immunosuppressive. And if it is a genetic thing, then the treatment entirely differs. So it is important that you pick up the genetic cause as a cause of focal segmental glomerulosclerosis. Now, this is taken from the slide from C. Jason. How do you treat FSGS? Now, FSGS lesion on a biopsy, then you presume it to be primary FSGS. Then the treatment goes on with the immunosuppressive agents. Then if it is secondary FSGS, you have to treat the underlying cause, and FSGS of undetermined cause, then you have to think about genetic testing. And there are certain markers, there are certain indications where you where you do a genetic testing, which I'll come to it later. Now, what happened to our patient? So the genetic studies which showed a targeted gene panel, it showed a mutation in the WT1 gene. It was a missense mutation in the exon 9. And the implications of having such a mutation is this patient is prone for developing a Dennis-Drash syndrome, which is characterized by a triad of progressive renal failure, male pseudohermaphroditism, and Wilms tumor. So this patient was advised to stop the immunosuppression, advised bilateral nephrectomy because they can develop Wilms tumor in the future, and a renal transplant. So this is an era of precision medicine. So this treatment is entirely very precise. So this is one classical example of one is known as a precision medicine. Now, a little bit of genetics. Now, this is a whole story of genetics starting from the Austrian monk Gregor Mendel, who is known as the father of modern genetics, down to the onset of the Human Genome Project, which was started by the US government, which was completed somewhere in 2002 and published in Nature. So we have come a long way in genetics. So the human genome sequence was first published in Nature, and this human genome has about 3 billion nucleotides, which is a blueprint for life. And it took nearly 20 years to read the full genome. Now the DNA sequencers can read the genomes within 24 hours with the evolution of next generation sequencing. Now, as you know, the cells contain the chromatin, and the chromatin contains the DNA, which is present in a highly compressed form, and the base is a sugar phosphate backbone, and which are linked together by the nitrogenous bases. Now, the whole the gene or the coding or the segment or the genes consist of the introns as well as exons. Exons are the coding sequences for amino acids, and there are as well as introns. So the exons are the protein coding parts of the DNA. Now, if you have a problem with the DNA, it is called a genetic variant. So any alteration or change in the reference DNA nucleotide sequence is a genetic variant, and it can occur anywhere within the DNA sequence, and it can involve one or two multiple nucleotides, and can be inherited, that is passed from the parent to the child, or occur de novo, occur for the first time in individual, or occur during a person's lifetime. And it can be a normal variation, it can cause disease or something in between, and some variants can even confer protection against diseases. So what are the targets for sequencing? So the whole genome, if you take the whole genome, there are about 20,000 genes in our genome. And this coding portion of the genes is called the exome. So of the total genome, 99% is non-coding and only 1% is a exome. Now coming to the exomes, around 4,700 are associated with a Mendelian disorder, and this can be classified as a Mendeliome or a medical exome. And so this is something like the whole, if you take the whole genome, the disease associated is only 4,700 out of the 20,000. And within the Mendeliome, if you take of this 20%, within the Mendeliome, if you take the number of genes which are associated with the kidney diseases, it's only about 16%. So this is a approximate distribution of the monogenic genes causing kidney diseases. So what is epidemiology? What is epidemiology of monogenic kidney diseases? So there are publications from the Americans as well as from the Australians, more or less concur, and about 10% of the chronic kidney diseases are thought to be monogenic in origin, which is confirmed by the two studies. So how do you do a genetic test? So you take a buccal swab, saliva test, or from the blood, and you look at the DNA. So with the advantage with the arrival of the next generation sequencing, the whole DNA sequence can be analyzed and sequenced very fast. So this is a next generation sequencing, and you get a high through output sequencing, and you get the whole genome sequenced. Now, what are the types of the tests, and what problems can happen? So there are microarray tests. So the microarray tests, these are the types of genetic tests that are done. So these are the microarray tests, and the microarray tests look at large structural problems within a chromosome, and these are typically it is an extension or the advantage or the upgradation of the classical karyotyping test, and you can look at the copy number variants with this microarray techniques. And then you have the Sanger sequencing, and the Sanger sequencing focuses on a particular gene. This is the original DNA sequencing, which was described by Sanger way back in 80s, and this is still one of the gold standard tests if you are looking at one particular gene. So if you are looking at a particular gene, then the best probable test would be a Sanger sequence. Then if you are looking at one particular phenotype, and if you know the number of the genes which are associated, for example, in nephrotic syndrome, there are about 63 candidate genes, or 53 are autosomal recessive and 10 are autosomal dominant. You can do a targeted gene panel. And this looks at the specific genes which are involved in nephrotic syndrome. Then you have the exome sequencing. The exome sequencing looks at the whole exome, and the whole exome is a coding region of the DNA, and that is a whole exome sequencing. Then you have the whole genome sequencing, where you look at both the exons as well as the introns. So these are the different gene testing options which are available now. So all these things can have advantages as well as disadvantages. And I'm just focusing on targeted panels. So the targeted panels, the primary scope is for the identification of genes of a particular interest for a particular clinical phenotype. The major advantages is it does a thorough analysis of all the genes probably related to the specific phenotypes. And because the number of the genes are restricted, and it minimizes the risk of secondary findings. We will tell what is a secondary finding, and it reduces analysis time. So the major disadvantage is that the limited reanalysis utility, and the reliability depends upon the challenging panel design. And the primary use is patients with phenotypes pointing to a specific disorder and with a low genetic heterogeneity. One typical example where you use is a nephrotic syndrome. Then you can use an exome sequencing, where you sequence a whole exome. So the primary scope is identification of small variants like SNPs, indels, copy number variants, all within the coding region of the genome. So it does the analysis of all the coding regions in the genome. And the major disadvantage is the coverage per base is generally lower than with the targeted panels. And you can have a lot of secondary findings. This is like ordering and suppose you are using an exome sequencing or a whole genome sequencing. This is just like analogous. You do have a clinical scenario where you have a patient with some pathology in the lung, which you suspect, and you are ordering a whole body MRI scan or a CT scan in um, instead of doing a CT scan of the chest. So you will get a lot of additional findings, and you will be stuck with it, and you will have no idea about what to do next. So this is a problem of doing a whole exome sequencing in certain particular diseases, or if you are doing a whole genome sequencing. And the primary use is in screening of patients with the undefined phenotype and patients with the heterogeneous or unspecific phenotypes. Now, what is the yield of these genetic results? So the yield of the genetics results are much higher if you have got a particular phenotype, then like if you have got a certain extrarenal features, if the age of onset is less, if there is a family history of kidney disease, and if a kidney disease subtype, then the diagnostic yield is much high. So this is a diagnostic yield in various diseases like tubular disorder, cystic diseases, glomerular diseases, then unidentified kidney diseases, unknown kidney diseases, Kakut, all these things. So what are the potential benefits of doing a genetic testing? So if you get a negative result, like if the patient is a donor, it enables kidney donation, reduces the risk in recurrence in the family member, depending upon the family history of the disease. And the positive result can confirm a suspected clinical diagnosis. It can impact clinical management. It can impact living donor donation. It can end a diagnostic odyssey. It can impact family planning. And you can do what is known as a cascade testing. Like cascade testing is early diagnostic testing of the affected family members. So these are the advantages of doing a genetic testing. So the genetic testing, it provides clinical information. It results in an end of diagnostic odyssey. Like the patient needs not to run from pillar to pillar to get a diagnosis. It enables research programs. You can inform the family file, and you can always have a closure of the disease and an answer to why. So all these things can be answered by a genetic test. So however, there are some risks and limitations of genetic testing. So you can have a false positive test. Again, sample mishandling can happen within the lab. All these things can happen within the genetic lab itself. And you can have a wrong variant classification, wrong diagnosis. Risk of incorrect diagnosis can lead to incorrect clinical management, incorrect prognosis, and faulty family planning. And it can miss the true diagnosis. And a false negative result, not all tests can have the same sensitivity. Some genes are harder to analyze, some variants are harder to interpret, and it can lead to a wrong diagnosis, can lead to inappropriate management, false reassurance, and prevent future diagnostic that could have been diagnostic. So all these are limitations of doing a genetic testing. Now, the American College of Medical Genetics and the American College of the Association of Molecular Pathology, they have standardized how to define how to report a genetic test. So the genetic test can be reported as benign, likely benign, uncertain, likely pathogenic, and pathogenic. Now, these two are generally considered as negative results, and these two are generally considered as positive result. Now, the problem comes with the variant of uncertain significance. Now, the pathogenic variants directly contribute or cause the development of the disease. So this likely pathogenic and pathogenic, you should take it as a positive test, and you should take it as a positive genetic test. Now, variant of uncertain significance can have an uncertain or unknown relationship to the disease, and they are not considered disease and causing, and should not be used in clinical decision making. And it can be with the advance of research and the acquisition of new knowledge and new interpretation guidelines, this category can change into pathogenic, or it can go to likely benign. So this is regarding variant of uncertain significance. So you have to take into evidence, you have to keep in mind the categorization of a problem with the variant of unknown significance can change with time. Now, if you got a positive result, the first thing that you have to do when you get a positive result is that you have to see whether the genetic diagnosis matches the clinical presentation. If yes, and you should you should think whether the patient should be referred to other specialists. Like some of these nephrotic syndrome patients can have cardiac problem, they can have renal issues, they can have bone issues. Then you have to see whether the treatment plan should be amended, should the family members be involved. And if there is a note, if the genetic diagnosis doesn't match a clinical presentation, or if there is a candidate variant of uncertain significance, then the most important thing that you have to do is to talk to the lab, and you have to speak directly to the medical geneticist to determine whether additional tests could change the variance classification. So this is generally the action that you take when you get a genetic test which is positive or negative. Now we'll come to that is regarding genetics, which is actually very short with regards to this topic, as well as genetics as a whole. Now we'll come to the inherited nephrotic syndromes. Now, if you take all the steroid-resistant nephrotic syndromes, approximately around there are large trials which have shown that about 30% of all these steroid-resistant, I am focusing on steroid-resistant nephrotic syndromes, about 30% can have a genetic basis. and the genetic basis is usually a monogenic disorder. So this is a study which is published in Kidney International in 2018. Again, they have looked at patients, around 135 patients with steroid-resistant nephrotic syndrome. They did the genetic testing, and they found out there are around approximately 78% didn't have any genetic mutations. Then around 30% had genetic mutations, either monogenic mutations and APOL1 gene mutations, as primarily studied in African population also. So this is a incidence of monogenic disorders in steroid-resistant nephrotic syndrome. Now, this is a figure, or this is a cartoon which shows a podocyte. This is a glomerular basement membrane. This is endothelial cells. So there are candidate genes. Around 63 genes are implicated in monogenic disorders affecting the which can cause nephrotic syndrome in infancy, childhood, as well as late adolescence. So the problem can happen within the structural genes of the podocyte, or with the genes which are involved in the function of the podocyte. For example, in coenzyme Q biosynthesis, there are problems. There are genes which are involved in the mitochondrial function of the podocyte. So all the red ones are recessive, all the blue ones are dominant, and around 53 genes are implicated in recessive inheritance, and 10 genes are involved in dominant inheritance. So you can have coenzyme Q biosynthesis. There are genes which are involved in endosomal trafficking. There are genes which are involved in the function of the nucleoporins. There are genes which are involved in the function of the lysosome. There are genes involved in the metabolism of the podocyte. Then there are genes involved in the tRNA modification. Then there are genes which are the classical gene LAMP2 mutations, which are involved in mutation of the laminin, which is a structural protein which binds podocyte to the glomerular basement membrane. Then there are proteins which are involved in actin binding. There are proteins which are involved in the slit membrane. In fact, the NPHS1 and NPHS2 coding for the nephrin and podosin are proteins which are involved in the structure of the slit membrane. Then actin regulation genes are also there. So it is a huge list, and this is a current list as of now. And probably as the research progresses, we'll add on more genes. And so this is going to be a subspecialty of on its own. So a geneticist involved in the analysis of renal disease would be a subspecialty in nephrology, or might be taken over by the medical genetics. So the problem can be within the podocyte. Again, different visualization of the previous slide, like podocyte problems, like mitochondrial functions, membrane function, lysosomal and endocytic function, metabolic and cytosolic functions, cytosolic scaffold, nuclear proteins and transcription factors, slit diaphragm, then glomerular basement membrane receptors, then endothelial cells. All these the disease-causing genes can be categorized by cellular localization based on the genes as well as the structural proteins. Now, this is a diagram which shows causative genes by the age of onset. And if you look at less than 3 months, any onset of nephrotic syndrome less than 3 months is known as congenital nephrotic syndrome. And apart from certain congenital infections like congenital syphilis, cytomegalovirus, the majority, around 99% are caused by mutations in NPHS1 or NPHS2 genes. And the age of onset is less than 3 months, and the presentation is something like this. And up to, in general, this hereditary or the inherited nephrotic syndrome, you have to suspect strongly up to the age of 12 to 18 years. And after 18 years, the age of presentation is rather unlikely. But still, there are certain situations, there are certain genes which can manifest even up to the age of 25 years. So less than 25 years, you have to think about an inherited cause of nephrotic syndrome. If you don't get answers to what the cause of a nephrotic syndrome is. So with regards to the age, the maximum diagnostic yield of a inherited nephrotic or a monogenic genetic cause of nephrotic syndrome will be less than 3 months of age. And as you see, the incidence of monogenic nephrotic syndrome decreases as age advances. So this is in general with regards to monogenic nephrotic syndromes. So these are the genes. So the genes which cause nephrotic syndrome that first manifest in adolescents or adults, these are generally autosomal dominant. And among these, so in late manifestation in adolescents and adults, you have to think about mainly autosomal dominant genes. These are the classical genes and the manifestations. There are a lot of extrarenal manifestations also, which will come to it later. Then, uh, then if it in infancy or the early childhood, then you have the NPHS, NPHS1, the epsilon receptor genes, LAN2 genes, SMARCL genes, all these genes are there. So lot of genes and lot of presentations. So there are reference websites which are available where you can put your the phenotypic character, and they will the website will tell you probably what you are dealing with. So there are syndromic proteinuria kidney diseases, again, the monogenetic disorders. This can present as nephrotic syndrome. Often these, because it is syndromic, you have a lot of extrarenal manifestations like progressive myoclonic epilepsy in AMRF syndrome. Then you can have sensory neural deafness, skeletal abnormalities, peripheral neuropathy. Then Dennis-Drash is a classical example with the case which I had discussed earlier, where you can have a male pseudohermaphroditism, progressive glomerulomegaly, and the development of Wilms tumor. Then you can have Fraser syndrome again. You can have male pseudohermaphroditism, and you have to, in such a disease, you should screen for gonadoblastoma, and there is a high incidence of gonadoblastoma in these patients. And you have Galloway-Mauer syndrome, where you have microcephaly, abnormal cerebral gyral patterns, seizures, psychomotor delay. In general, any dysmorphic feature associated with the nephrotic syndrome, you should strongly think about you are dealing with a monogenetic cause. Then nail patella syndrome can again present with the nephrotic syndrome. Then Pearson syndrome, you can have microchoria. There's a LAN2 mutation. Then there is a hypoplasia of the ciliary body, and this results in a fixed narrowing of the pupil. Then you can have Shinkes immunoosseous dysplasia, where you can have lot of skeletal abnormality, and you can have endocrine disorders in these syndromes. So what is a management of a child with a steroid-resistant nephrotic syndrome? So a steroid-resistant nephrotic syndrome is an absence of complete remission after 4 weeks of daily prednisolone at a dose of 60 milligram per meter square. And if you do a genetic test, then the one thing that is important is that you have to look for a mutation in the coenzyme Q10 biosynthetic pathway. And if there is a problem in the coenzyme Q biosynthetic pathway, many of the cases will respond to a coenzyme Q10 supplementation as well as ACE inhibitors. So this is one thing that has to be kept in mind. And if there is no other mutations which are identified, then you have to treat with ACE or ARB, and you have to stop immunosuppression, because you are causing more harm in treating these patients with immunosuppressive agents. And it is interesting to note that there is wide range of genotype phenotype association disparity in some of these syndromes, and it is described in some genotypes that these patients can respond to steroids. You'll have to refer the Excite books to know which there are some genotypes which can again respond to steroids or calcineurin inhibitors. So if it is a congenital nephrotic syndrome, 99% sure that almost 100% sure that you are dealing with a inherited nephrotic syndrome that is less than 3 months. Straight away go for a genetic testing, and you have to manage accordingly. And most of the times it is a supportive treatment with IV albumin infusion, then maybe ACE inhibitors, medical nephrectomy, and a transplant once the child has attained more than 10 kilos of age. Then if it is 1 year to adolescence, then you have to then again, if after 4 weeks of oral steroids if there is no remission, then you'll have to think about doing a genetic test, and you'll have to take it from there. Now the various extrarenal, what all things that you should look in a child with when you're suspecting a steroid resistant nephrotic syndrome. You have to look at the mental retardation and microcephaly. The skin can have epidermolysis bullosa. you can have a heart block disorder. Then a lot of things can have isolated kidney involvement. Then if you are having an immunoosseous dysplasia, you are probably dealing with a Schimke's disease, nail patella syndrome. So look at whether the patella is intact or not. Then glycosylation deficiency, Charcot-Marie-Tooth associations are there. Dennis-Drash is there. Then if you are having thrombocytopenia or giant platelets, then you are probably dealing with this one. Then microchoria, cataract, myopia or nystagmus, you are dealing with a Pearson. Then hearing loss or myoclonia, probably you are dealing with this. And this mitochondrial cytopathies can present with seizures, ataxia, encephalopathy. All these are characteristic of mitochondrial problems. So this is in general the extrarenal manifestations that you look in a child with steroid-resistant nephrotic syndrome. So this table gives you the complete list of genetic mutations along with the extrarenal manifestations. So a lot of things are there. It is quite impossible to memorize and to know it all these things by heart. So you have you have the website, and there are a lot of sites which will help you in getting a clear diagnosis. So this table is taken. So when should you do a genetic testing in a patient with a steroid-resistant nephrotic syndrome? This is taken from the guidelines which is published by the International Pediatric Association of Nephrology. So the recommendation is that any child with a primary steroid-resistant nephrotic syndrome, they recommend to do a genetic testing. And if there is a family history extrarenal feature, again, strong indicator for doing a genetic testing. Then familial, and if they are dealing with a syndromic case or a genetic cause of SR, steroid-resistant nephrotic syndrome, it's very strong recommendation. And they often recommend a genetic testing before a kidney biopsy in children with steroid-resistant nephrotic syndrome in most of the cases. Then if the child responded to steroid initially and then subsequently became a steroid non-responder, don't do a genetic testing. This is a recommendation by the Pediatric Nephrology, International Pediatric Nephrology Association. So when to suspect a monogenic disease, familial, but often you have to remember that autosomal recessive disorders would not be occurring as you won't get a beautiful pedigree as in this chart. Earlier onset, extreme phenotypes, so the phenotypes go into the extremes. Then if you have got a syndromic one, then strongly you have to think about a monogenic disease. Now you have made a diagnosis. So you have got a child with the first case, as I discussed. So the child with a suspected Dennis-Drash, and you have asked the patient for a transplant. Now the relative has come forward to donate a kidney. Now, so because it is a genetic disorder, then you have to screen the relative also. So there are certain guidelines which is published in HKD 2024. So this is a guideline which tells you how to proceed with the genetic testing and how to deal with such a donor. So what is going to happen in the future is a bit exciting. So it can be early intervention. So it prevents irreversible kidney failure. Then you have personalized medicine and precision medicine, where you got tailor-made approaches based on genetic profiles, and probably with the advent of CRISPR and other gene editing tools, you can have gene editing and targeted therapies to correct underlying mutations. So this is a current paradigm. So the patient goes to the physician, workup, genetic testing, and you formulate a plan. So in the future, this is going to be something like this. So the patient with the genetic sequence goes to the physician, workup, and plan. So the future paradigms might change, and we all can speculate what the future is going to be. Now, this is an interesting thing which has come. So this is a APOL 1 variant. As you know, there's a APOL 1 variant, which is highly prevalent in African Americans. And they, because of this, these African Americans develop secondary FSGS and end-stage kidney disease. And this is one of the diseases which leads to a very high mortality in this patients population. And these patients are also prone for developing hypertensive nephropathy. So there's a article published in the New England Journal of Medicine. So this is a inaxaplin So the inaxaplin, what is it? What it this is said when you have an APOL1 channel gene polymorphism, it leads to a gain of function of a protein, and this inaxaplin will block the activity of this APOL1 oligomer. And they have shown that there is a drastic reduction in the proteinuria. So pharmacogenetics and other things can happen in the future. So a lot of new drugs might come up in the future. So this is if you are interested in astronomy, this is a Helix nebula. So this Helix nebula is the representation of a star which is dying out something like 650 light years from our planet, and this is often described as in astronomy as an eye of God. Thank you.
Thank you, Jose. That was a wonderful journey into the basics of genetics and also into genetically mediated nephrotic